The Patch Trauma Trial, a comprehensive review. Welcome to the Everything Surgery podcast, where we explore the latest advancements and critical studies shaping trauma care. Today, we bring you an in-depth discussion of the Patch Trauma Trial, Prehospital Antifibrinolytic Therapy for Traumatic Coagulopathy and Hemorrhage, a pivotal investigation that has influenced modern trauma management in Australia, New Zealand, and Germany. Background and rationale. Severe trauma remains one of the leading causes of death across the globe, with uncontrolled bleeding being a major contributor to early mortality. A significant challenge in trauma care is the phenomenon known as trauma-induced coagulopathy, where the blood's ability to clot is severely impaired, leading to excessive and sometimes fatal bleeding. Tranexamic acid is a cost-effective and widely available medication that works by preventing the breakdown of blood clots, a process known as fibrinolysis. The landmark CRASH-2 trial in 2010 established that administering tranexamic acid within 3 hours of injury in a hospital setting reduced mortality for trauma patients experiencing significant bleeding. However, it left a crucial question unanswered: would giving tranexamic acid even earlier, such as in the ambulance or helicopter, offer greater protection by preventing coagulopathy before it fully develops? Trial design and methods. The Patch Trauma Trial sought to answer this question through a multi-center, randomized, double-blind, placebo-controlled study. It enrolled 1,310 adult patients who had suffered severe injuries, as assessed by paramedics. Inclusion criteria required a systolic blood pressure below 90 mm of mercury or a heart rate exceeding 110 beats per minute, and all patients were within 3 hours of sustaining their injuries. Participants in the intervention group received 1 gram of tranexamic acid intravenously while still in the pre-hospital setting, followed by an additional 1 gram infusion over 8 hours after hospital arrival. The control group received a matching placebo in both settings. The primary outcome measured was survival with a favorable functional status at 6 months, assessed using the Glasgow Outcome Scale Extended. Importantly, a favorable outcome was defined as a score indicating moderate disability to full recovery, not merely survival alone. Major findings. The findings, published in 2020, revealed no significant benefit for the primary outcome. At 6 months, 53.5% of patients who received tranexamic acid were alive with a favorable functional outcome, compared to 53.3% in the placebo group, a difference that was not statistically significant. All-cause mortality rates were also similar, with 18% in the tranexamic acid group and 19.8% in the placebo group, indicating no meaningful difference. Subgroup analyses and safety considerations. One critical subgroup analysis focused on patients with severe traumatic brain injury, as defined by a Glasgow Coma Scale score between 3 and 8. Here, the data suggested a possible signal for harm. Patients receiving tranexamic acid in this subgroup experienced higher mortality and worse functional outcomes compared to those who received placebo. However, it is important to interpret this finding cautiously, as it arose from a pre-planned subgroup analysis rather than the main trial results. Regarding safety, there was no significant increase in thromboembolic events such as deep vein thrombosis, pulmonary embolism, stroke, or myocardial infarction in the group treated with tranexamic acid. This finding helps address earlier concerns about potential risks associated with the medication. Conclusions and implications. The Patch Trauma Trial concluded that administering tranexamic acid in the pre-hospital phase did not provide additional benefit over in-hospital administration for improving long-term functional outcomes in severely injured trauma patients. These results challenge the commonly held belief that earlier administration is always better and suggest that the context and type of injury are crucial factors in determining the benefit of antifibrinolytic therapy. Notably, the trial's findings do not undermine the established practice of giving tranexamic acid to trauma patients with significant bleeding within 3 hours of injury in the hospital setting, a practice supported by robust evidence from previous studies. However, the enthusiasm for universal pre-hospital administration of tranexamic acid is now tempered, especially considering the potential for harm observed in patients with severe traumatic brain injury. Future directions. The Patch Trauma Trial highlights the need for a more personalized approach to trauma resuscitation. Future research may focus on using point-of-care testing to identify which patients are most likely to benefit from tranexamic acid, particularly those with hyperfibrinolysis, and to avoid use in patients, such as some with severe traumatic brain injury, where it may be harmful. Thank you for joining us for this comprehensive review. We appreciate your support. If you find our content valuable, please like, share, and subscribe. This is the Everything Surgery Podcast, where we continue to dissect the extraordinary.